to ED with hyponatremia, which this is a very important, are stable and does not require emergent therapy. So as a practice, most of us at emergency department, whenever we saw a patient with low sodium, we go ahead and start shooting 1 liter of normal saline without knowing is this patient need or require an intervention now or no. So most of our patients who present to our emergencies does not require emergent treatment of their hyponatremia. So for me as an emergency physician, if I am treating a patient with hyponatremia, this is my way, and this is like a way to divide the hyponatremia. Is this hyponatremia need urgent intervention or no? So if I face a patient with hyponatremia, I should ask myself 2 questions. Is this a true hyponatremia? And the second question will be, is this patient need urgent treatment or urgent correction? So for the first question, for hyponatremia, this is a very famous figure. So as we know all, hyponatremia is sodium below 135. So here will be the pseudo or not a true hyponatremia. One will be either normal osmolarity or high osmolarity. In case of normal osmolarity, like multiple myeloma, hyperlipidemia, this case of hyponatremia will be treat the underlying cause. If the osmolarity is high, as what happened in hyperosmolar hyperglycemia, hyperglycemia, mannitol use and contrast, also here will be treat the underlying cause. So this part of hyponatremia are not the true hyponatremia that need intervention and correction of sodium, rather than correction of the underlying cause. And here we go to the true hyponatremia that we should worry about when the serum osmolarity is low. So this is the osmolar hyponatremia. It's divided to hypovolemic, eovolemic, and hypervolemic. So if I have a hypoosmolar hyponatremia, I should go and check my patient volume status. If the patient is hypovolemic, or eovolemic, or hypervolemic, and we will treat our patient based on the volume status. So this is basically the type of hyponatremia. So then, as we said, the second question is this patient need an urgent treatment? As we know, hyponatremia can cause life-threatening complications as altered mental status, a focal neurological deficit, active seizure. So when does my hyponatremic patient require urgent treatment? If my patient's sodium level is less than 120 milliequivalent per liter, plus one of those 3, either altered mental status, focal deficit, or active seizure. So how does I treat my patient in this scenario? Then the medication or the treatment of choice will be hypertonic saline or 3% normal saline. So will be there is a different approaches. This is one of the most commonly used approaches, to give a bolus of 100 ml IV over 10 minutes. Then if needed, you can repeat other 100 ml. So the 100 ml, other people or other references, they go with 1 to 2 ml per kg of hypertonic saline as a bolus over 10 minutes. The target is not to increase the sodium more than 6 millimole over the first 24 hours. And if it was necessary, not exceeding more than 12 to prevent or minimize the risk of myelinosis or central demyelinosis syndrome. So this was as for the emergency part of hyponatremia. Then I will go just briefly about the other options of treatment of hyponatremia, which I will not talk a lot about. We'll focus mainly on the emergency part of the hyponatremia. As we said, the hyponatremia, the true hyponatremia divided into 3: hypovolemic, hypervolemic, or eovolemic. If my patient, I decided that my patient is hypovolemic, true hypovolemia with hyponatremia with hypovolemic status, so the treatment will be replace the deficit. First of all, replace the volume deficit by normal saline. Then I should apply the calculations to make sure that I am not replacing the sodium more than 6 or 8 milliequivalent per 24 hour. I will not go through these calculations because this is like a complicated, and it's only a equation that you should apply it and enter the numbers. If my patient is hypervolemic hyponatremia, the treatment will be either restriction of fluid and sodium, loop diuretics, and hemodialysis. In case of heart failure, will be restriction fluid and sodium. In case of patient with chronic kidney disease or end-stage renal disease, dialysis might be an option. So it depends on the underlying cause of this hypervolemic hyponatremia. And lastly, the eovolemic hyponatremia, which can cause by Seada syndrome, by hypothyroidism, and some antipsychotic medication. Here will be free water restriction, uh, treatment of Seada if it's present, and also one of the common causes of eovolemic hyponatremia is psychogenic polydipsia. So here will be mainly free water restriction and the treatment of this hyponatremia or type of hyponatremia. So this was briefly about sodium, a high yield point, how to treat and how to approach a patient with hyponatremia. Um, this is what I keep mentioning about the scary complication of overcorrection of hyponatremia, which what we call osmotic demyelinating syndrome. It's occur when too rapid correction of sodium happen. Patient with central pontine melanosis have a flaccid paralysis initially, dysarthria, dysphagia, and hypotension. So if your patient if your hyponatremic patient who you started on correction started to have this kind of symptoms during the correction, you should stop all the sodium containing fluids and start administering D5 water immediately to lower the sodium values temporarily. There is other options of medications that you can use. We will not go through it, but this is uh, the only thing, the most important thing that you should anticipate and think about when you start to treat your hyponatremic patient. Think about this complication and try as much as you can to prevent and minimize the risk of this complication. So this was briefly about sodium. I will go to the other very important and common electrolyte abnormalities that we face in emergency departments. With hypokalemia, I will talk basically about hypo and hyperkalemia briefly, both abnormalities of potassium. So hypokalemia is defined as a potassium level less than 3.5. Usually, again, our patient will be asymptomatic. They might present with non-specific symptoms as palpitation, muscle weakness, easy fatigability, depression, muscle pain. But again, it's non-specific except in the severe form when patient have respiratory paralysis, muscle weakness, and all this. It may cause fatal arrhythmias and hemodynamic instabilities. And in rare extent, it causes hypokalemic periodic paralysis, which is a rare disorder characterized by a potentially fatal episode of muscle weakness through, and it will involve the respiratory muscle also. This is again symptoms of hypokalemia, shallow respiration, irritability, confusion, weakness, arrhythmias, lethargy, and 3D pulse, instability, and mortality. And this is a summary. So again, the same approach. If I face a patient who is hypokalemic, so as an emergency physician, I should ask myself two important questions. It will direct me and it will decide how urgent and how emergent is my intervention. If there is any ECG changes or arrhythmias, or is any muscular weakness, specifically respiratory. Though the evidence of one of those, it will mandate an emergency-based correction and urgent action. So this is the ECG changes or the arrhythmias caused by hypokalemia, starting by ST depression, flattened T wave, U wave, and ending by prolonged QT interval. This might again lead the patient to have fatal arrhythmias if not treated early. So Flattened T wave, U wave, ST depression, and prolonged QT. Prolonged QT is one of the most important and common finding in hypokalemic patients. The other question will be, is there is any muscular weakness? And this will be by history and clinical exam. Be worried about respiratory muscle weakness specifically. Because again, in severe form of hypokalemia, and especially if this is a periodic hypokalemic paralysis, patient might present with respiratory failure because of or secondary to hypokalemia. So treatment, the treatment is based on two factors, the level and the symptoms. So you are not treating only numbers, you are treating combination of a number of symptoms. So if your patient have mild to moderate hypokalemia, which sodium potassium more than 3, and asymptomatic, this is very important, oral replacement will be enough. So no need to have your patient on IV replacement. So oral replacement plus advising to high potassium diet like bananas, dates, and some and others. Again, if your patient is asymptomatic. If you go to the second part or second option, if you have your potassium level is less than 2.5, or your patient is symptomatic in form of arrhythmias or ECG changes or muscular weakness, here the approach will be totally different. You should start your patient on a cardiac monitor, insert an IV lines, and start potassium infusion. So for the potassium infusion, it should be 10 milliequivalent per hour in the peripheral line, with or 20 milliequivalent per hour in the central line. And you can always add the oral placement at any power, any one of those options. It will facilitate and buy you time and it will correct the potassium fastly. So why here? What is behind 10, the 10 milliequivalent in peripheral? And there are some references they go to up to 20 milliequivalent if you have big peripheral vein like anticubital, but most of the hospital policies they go with 10 milliequivalent per hour in the peripheral line. So go with the safest option, or 20 milliequivalent through the central line. Why? Because potassium infusion will burn small veins if it's concentrated and fast. So this is behind this, to protect from the local complication of the potassium infusion. Hypokalemia also associated, this is an important factor that we forget about sometimes. Hypokalemia is associated with hypomagnesemia. So magnesium replacement should usually accompany potassium. Sometimes you keep treating your patient potassium level, and although there is no response, then out of nowhere you discover that he was hypomagnesemic. So persistent, especially if you have severe or persistent hypokalemia, always think about magnesium. So you will never be able to correct the potassium without correcting magnesium level. This was basically about hypokalemia. Again, I'm focusing on the important parts and important aspects in emergency. I will not go in details. Lastly, hyperkalemia. So hyperkalemia is defined as serum potassium level greater than 5 milliequivalent per liter. So patients vary from asymptomatic to having severe symptoms, including GI symptoms like nausea, vomiting, diarrhea, neuromuscular symptoms, and cardiac instability. And here is the cardiac instability, the most worrisome and scary part of the hyperkalemia. And we'll talk about it somehow now. Again, this is a summary about the potassium hyperkalemia symptoms. Arrhythmias and ECG changes are the most important thing to worry about in your hyperkalemic patient. About reasons for hyperkalemia, this is somehow important. The most common cause of hyperkalemia is sucrose or a false elevation of potassium. What can cause this? Hemolysis of the blood, starting from taking or extracting blood in a small needle, prolonged use of tourniquet, prolonged tapping in the veins, then to the prolonged or the improper handling of the tube that filled with the blood. All these factors can cause hemolysis of the blood. So always, if this is not does not make sense clinically with your patient, think about false or pseudo hyperkalemia secondary to sampling error before jumping to starting management if there is no clear evidence or clinical signs of other clinical signs of hyperkalemia. So always check about this is pseudo or true. Renal failure is the most common cause of confirmed hyperkalemia. And here, the worrisome part of hyperkalemia. Initially, hyperkalemia in the early phases can cause cardiac toxicity by increasing the membrane potential of cardiac myocytes. So initially, the heart will be excited. It will increase the excitability, so and decrease the threshold of any risky arrhythmias. And then, after a prolonged exposure of the hyperkalemia and at a very high levels, potassium will cause the deprolactin threshold to rise again and leading to overall cardiac function depression, then cardiac arrest, asystole, and others. So this is how hyperkalemia basically affect the heart. Again, as the other two electrolyte abnormalities, if I have a patient who's hyperkalemic, me as an emergency physician, I should ask myself two questions. Is this is a true hyperkalemia? And is there is any ECG changes or arrhythmias? The answer of those two questions will help me to and will direct my management how fast or urgent is my management. Two, so as I said, so the hyperkalemia due to leukocytosis, thrombocytosis, hemolysis, poor vein picture technique, prolonged tourniquet, improper handling of the sample. Always this is very helpful. Read the laboratory comments on the sample. So most of the labs nowadays, when you have all the electronic systems, they will write a comment from the lab that this sample is hemolyzed or repeat sample, or they will send you a message that this is a potentially false reading before jumping and treating your patient without looking about what is behind this result. Repeat the level for confirmation if this was not um, clinically justified. Like if you have a young patient with no any background comorbidities, and out of nowhere his potassium is 6 or 7. But the scenario will be different when you have a patient who's in the stage renal disease in dialysis and his serum potassium is 8. So the chances to be here will be different. So, okay, in the first scenario, I should make sure that this is true. There is no any sampling error. The second scenario, this is very logical to have this. So measure it clinically with the history and patient's background. But always consider false hyperkalemia. And the second question is there is any ECG changes or arrhythmias. So this is the typical textbook changes of or ECG changes in hyperkalemia, starting from tall or tended T wave to long PR interval, wide QRS, then to the sine wave. People still are reading from text. Most of us, we read text. It's mentioned there, the ECG changes that it's related to the potassium level. This is for theory, okay, from pathophysiology or physiological part, okay, but all the clinical evidence uh, showed that hyperkalemia can cause any cardiac arrhythmias at any level, and the value itself does not always predict the ECG changes or the degree of cardiac toxicity. So it's nice to know at which level at each level of potassium what is expected to change, but in the clinical life, potassium of 6 can cause VTAC in one patient and potassium of 7 or 8 in other patients who tolerate chronic hyperkalemia, like in stage renal disease patient, will be with normal ECG. So again, the value itself does not always predict the degree of ECG changes and cardiac toxicity. So treatment, again, after stabilization of a patient, cardiac monitor, 12 lead ECGs. So I have three concepts to follow. The first, the most important, if it's there, stabilization of cardiac membrane, if indicated. The second will be shifting of potassium to intracellular components. And third concept will be removal of potassium. So I'll start talking about cardiac membrane stabilization. So First of all, as for cardiac membrane stabilization, the drug of choice will be calcium. Calcium can be used or should be used to stabilize cardiac membrane by restoring the electrical gradient. The usual dose will be 1000 milligram or 1 gram of calcium chloride or calcium gluconate. The difference between calcium chloride and gluconate, that calcium chloride is more potent. It have almost the um, three times more of calcium ingredient calcium comparing to calcium gluconate. It's in the active formula, so it does not need to be metabolized in the body to start to act. Um, the, the difference here that calcium chloride cannot be used in peripheral line except if your patient is in cardiac arrest. Otherwise, if you are using peripheral line, the only option will be calcium gluconate. The dose of either formulation can be repeated every 3 to 5 minutes if the ECG changes persist. Because so, if I have a patient who is with cardiac arrhythmias like beta secondary to hyperkalemia, I give the patient first dose of calcium, and no, still the ECG does not change. So I can repeat the calcium every 3 to 5 minutes until I reach the resolution or the normal ECG back for my patient. So you can repeat it. It's not only a single dose at all. You can repeat it every 3 to 5 minutes. The second part of management will be shifting the potassium to intracellular component um, by using the insulin, 10 units of insulin or zero point 0.1 unit per kg combined with 1 ml of dextrose. Here the dextrose does not work at all for hyperkalemia. The only indication for dextrose here to prevent the potential hypoglycemia secondary to the high dose of insulin. So if your patient is hyperglycemic already, you might not need to have the dextrose. So here, the dextrose only to protect from the potentially hypoglycemia secondary to the insulin. Ventolin and albuterol or beta agonist, it will be, the doses will be much higher than the doses we use for asthma. Also, it will work to shift the potassium from extracellular to intracellular component. And finally, sodium bicarb. But here, talking about sodium bicarb in patients with hyperkalemia, sodium bicarb will not work unless your patient is acidic. So with pH less than 7.2 approximately. Why? Because sodium bicarb will work on the hydrogen potassium pump. It will shift the hydrogen inside this outside the cell and shift and get the potassium back if you correct the acidosis. So again, sodium bicarb will not affect your potassium no benefit to give sodium bicarb for a patient with normal potassium, normal pH. And finally, removal of the potassium from the body. Hemolysis is the only reliable definitive method. If your patient have persistent hyperkalemia or refractory hyperkalemia which does not respond to the treatment, the only option is next option will be the dialysis, because as we know, 90% of our potassium in our bodies will be eliminated from the body by kidneys. So if my kidneys are not working, I will not be able to remove this excessive potassium unless I get help from outside, from help by hemodialysis. Um, and the second option, which not favorable, sodium or sodium sulfonate or caxalate, which also bind to potassium in the intestines and help to excrete potassium by feces. Talking about this, the onset of action of caxalate will be like 4 to 6 hours approximately. So it will not get any benefit for your patient in the emergency department. Plus the growing evidence and serious case reports about the significant side effect of caxalate on patients like intestinal obstruction, intestinal ischemia, and other complications. So people here will start to debate. I am from the team who does not prefer to use Caxylate at emergency department because of the unclear benefit and potential or high potential side effect from this medication. So finally, this was my talk about hyponatremia, hyperkalemia, briefly. So this is a rapid review about what I talked. So if I have a patient with hyponatremia, again, the two questions is this is a true hyponatremia by looking for this algorithm. Then the second will be, is this patient need urgent treatment, which will be if my sodium level is less than 120 with one of those indications. So the treatment will be a hypertonic saline. If I have a patient with hypokalemia, again, I ask myself, is there is any ECG changes or arrhythmias? And the second will be, is there is any muscular weakness or mainly respiratory? And finally, hyperkalemia, ask yourself, again, is this true or no? And ask and check your patient ECG. It will direct you how extreme or how urgent you should go with your hyperkalemia management and what will be your line of treatment. And thank you so much.
Thank you very much, Dr. Mohammed Arafat, for impressive lectures. And we welcome the other panelists with us, Dr. Bayan Abdulbaqi, Senior Emergency Medicine Consultant and Toxicologist faculty member, Dr. Hani Ibrahim, Senior Emergency Medicine Consultant and faculty member. He's interested also in ECGs and resuscitation. We have two questions for Dr. Mohammed Arafat. He's one of the senior consultants in emergency medicine faculty member as well, and he is very interested in research. He's very interested in education and resuscitation. Dr. Mohammed, you have a question from Hanan Al-Ubaid. She's asking, do we have any adverse event of high dose beta agonist in case of using it frequently for hyperkalemia?
Okay, so as we know, using beta 2 agonist will cause tachycardia and sometimes, rarely arrhythmias. But in this indication or in this situation, you should use higher doses. You might have an approach to prevent or to minimize side effect, not side effect of beta agonist, to give this continuous nebulizer over 20 to 30 minutes. This might minimize the side effect, but we should not worry about side effect unless we have a patient with significant risk factors, like a patient with history of refractory VTAC, patient who had significant risk of arrhythmias, or ICDs who tachycardia might induce significant risk. Otherwise, if there is no risk of arrhythmias, there is no significant harm if you go with this beta agonist.
Doctor, thank you. Dr. Mohammed, last question regarding the in presence of hypokalemia, I would like to give potassium IV peripherally. How fast we can go? This is a very common question we face every day in the emergency department. If we don't have a central line and you would like to speed up the management and the admission.
Okay, so talking about hypokalemia, I am not one of the people who favors doing central line for every hypokalemic patient, because again, the issue in hypokalemia that if you give it in a faster rate, it might cause local side effect on the small veins. So if you got two good peripheral line, using each line with 10 milliequivalent of potassium chloride per hour, so you can run 20 milliequivalent at the same time, at each line 10 milliequivalent. This will be equal to a central line, and this will minimize and deviate your patient from having a relatively invasive procedure for a short that will be needed for a short time to replace his potassium or her potassium.
Yeah. Thank you very much. Impressive lecture from Dr. Mohammed Arafat, Senior Emergency Medicine Consultant. And now we will move to Dr. Bayan Abdulbaqi, Senior ER Consultant and Toxicologist from King Saud University. Tfadal, Dr. Bayan, please go ahead. Dr. Bayan.
Yeah, hello.
Yes, the mic is yours, please.
Yeah, you see the lecture, I guess. You see the screen,
yes, thank
right?
you. You can go ahead and share your screen right away, Dr. Bayan.
Do you see it? Is it on?
Try again, please. Can you try again?
Okay. Here we go. Do you see it now?
Yes, please.
Awesome. أولاً كل عام وأنتم بخير. I wish that I could see you guys and I could see your reactions, but it's what it is. I was asked to give a talk about the update in tox and how to deal with the critical cases in tox. I know tox could be sometimes overwhelming, but we're going to learn a little bit of or some tools to get you to the other side. The first slide here is just interesting painter. He's an artist and he wanted to paint himself. That's actually all of those pictures are the same painting. He wanted to paint himself on a different medication. Here's on morphine, here's in mushrooms and marijuana, and you could see how the reality is distorted. The way they see the world is different. Those patients who are intoxicated, and so is. Here we go. And so is the presentation of the tox patient. They present to you different in a different way, and unless you think about it, the lab or the sophisticated management or knowledge sometime will not be used unless you really diagnose it. And not all the patients who are intoxicated, they come to you and they say, we are intoxicated. And so that's the biggest challenge here. They present to you high on some of the some sort of drug and you don't know what they are. They came to you simply in a seizure, unconscious. A child who are chewing on a grandma's medication, tons of medication, you don't know which one, that it's scary, which one he got. Bottom line, the history is usually unreliable. A suicidal note or whatever it is, you might not get a history, and so you have to rely on other tools to get you to the other side. And please don't feel overwhelmed. The tox is, think about it as support. You're supporting your patient regardless of the exact medication. If you try to read your patient, to really think what is the knowledge that you need to have to really read your patient, to see the clinical picture in front of you. And so in this talk, I'll try to give you some hints, and I hope you could enjoy the talk. A lot of time we need to think outside of the box. A seizing patient who present with seizure could have a trauma, a fever patient with, with confusion, sepsis comes in mind, but put in your mind some of the tox differential, and that's the only way you could help the intoxicated patient or the overdose patient by first thinking about it. For that reason, we're gonna attack this from another angle. I'm gonna go with the vital signs, not with the medication, because because they don't present to you saying, I am this medication, please treat me. I have this tox syndrome, please treat me. And so we're going to go from the other side, so you would have the exact tools how to read the patient. So we're going to start with the vital signs and tox. And just to review, if we think a little bit why, for example, the cocaine or the sympathomimetic will have fever, those guys will have increase in their metabolic rate, in the basal metabolic rate. And when you simply burn more glucose, you have more energy, and with that, you produce more heat. Now, why the anticholinergic and why the aspirin has also high fever, we're going to talk about it in the next slides. Now, on the other token, the hypothermia, in overdose patient, the hypothermia most of the time are central. Those medication, they go to the CNS and they turn off the thalamus. They turn off the set point. But again, we're going to learn more about those tricks and each medication, what does it do. This slide here, I'm not sure if I'm blocking you. Okay, so this slide here, you could see the mitochondria membrane building up some energy to actually produce ATP. The aspirin folks overdose, they build up all the energy, but they do not build the ATP. And so all of that energy dissipates as a heat. And so that's why it's a malignant. And I'm stressing on this point because of the management too. Please think of intoxicated patient or overdose patient as an overwhelmed liver. You've got overwhelmed system in that patient. You do not want to add more medication. And so if you have a feverish that you think that's an overdose patient, go with cooling rather than aspirin, because aspirin itself could be the cause. And don't add to the mix. Try not to add to the mix. Go with cooling. With anticholinergic, there is another trick here, and I think if you understand this, it will solve a lot of puzzles for you. If you remember back in medical school, the parasympathetic and the preganglionic and the postganglionic, and there were both acetylcholine receptor. This one is nicotinic receptor, this one is muscarinic, if you remember. The sympathetic, on the other hand, the preganglionic is acetylcholine, but at the end is norepinephrine, which has the alpha and the beta receptors and so on. But we've got here a very special exception, which is the sweat gland. The sweat gland actually innervated by sympathetic here. When you're scared, when you're excited, you are sweaty. But the end is acetylcholine. And so that's why in the cholinergic syndromes, namely the organophosphates, you are wet. And so for anticholinergic here, you cannot sweat. And so you cannot lose heat the way you should be. And so you develop the fever. And so it's a different twist to where the fever comes from. And that's just saying the same thing. When you see the patient is wet, most likely the sympathetic is going on or the acetylcholine is going on. When it's dry, then you know you've got the anticholinergic guys. Of course, you could be sweaty because you're stressed. Like the hypoglycemia is a stress. The sepsis is stress. A lot of heart failure, for example, patient, they present sweaty, not because they're intoxicated or they're overloaded, but because they're, you know, the steroid is going on, they're in stress. The blood pressure, on the other hand, you know, the blood pressure is high in the sympathetic, again, because you've got the beta receptor here cannot contract the blood vessels. And so when they don't contract, you've got hypotension in the beta blocker. You've got hypotension if you don't have calcium. If you remember again in back school, the actin and the myosin, you need the calcium to contract. And if you don't have that calcium, if you don't have that beta blocker, beta receptor, you're going to have hypotension. On the other token, the sympathetomimetic, again, because they work on the beta receptor, then those guys here, they will contract and you're going to have a reflexive hypertension. I want to say that tachycardia is not really specific. A lot of things could cause tachycardia, and it's not going to clue you into one thing or another. But the bradycardia here is a good clue. About the blockers that we talked about, the beta and the calcium, you've got DIG. It works on the heart, it slows the heart, and you could have a bradycardic patient, they're intoxicated on DIG. And what makes sense here, that also the organophosphate. Remember, if you have a bradycardia, the first thing you do is you give them atropine. You want to block those acetylcholine receptors. And here you have a lot of acetylcholine and your heart is simply slowing. If you've got a patient who you think he's overdosed and he has hypoxia, or she have hypoxia, then you've got one of those two things. Either the patient inhaled an irritant to the lung, a gas and irritant to the lung, or it is a late presentation of some of the overdose that could end up with pulmonary edema. And not a lot of medication do that. Aspirin do that, and some of the opioid does that too. So keep in mind, if they're hypoxic, either a gas or a late presentation. The blood sugar is also important of the vital signs, and it makes very sense that you have either insulin or sulfonylurea. But it's very important to differentiate between the two because the latter here, the sulfonylurea, it works more than 24 hours, or let's say around 24 hours. And so you cannot discharge those patients. They need to be they need to be on D5 or D10, sometime infusion all the time to prevent hypoglycemia. And hypoglycemia here is the killer, guys, not the hyperglycemia. There's another clue here. Part of the vital signs in tox is the pupil size. And you're going to understand a lot of the pupil size when you understand this diagram here. You've got two kind of muscles. Where is the mouse? You've got two kind of muscles in the eyes. One that is radial, and it's radiate around the pupils. And when those guys contract, they make the pupils wide. And so they contract when you're scared. These are the sympathetic guys. While there is a circular muscle here, when it contracts, it makes the pupils smaller, and you want those when you're focusing. And so here is the parasympathetic control going on. And so again, when you look at the pupils, sometime you would know which tox syndromes you're dealing with. Of course, the opioid, on the other hand, does not have a receptor here, because the opioid work up in the CNS, and it shut the whole thing, and the pupils is one of the central things it does. You've got another thing also, which is the skin color. I want to add that the hemoglobin or let's say the heme itself, it's a molecule that is very, very smart and very, very sensitive. When you change a small angle of a bond here or there, it changed completely its color. And it gives us the color of our skin and the urine. And, you know, when you have bruises somewhere, you've got all the rainbow colors going on because of the heme different metabolite that each one of those had their beautiful colors. If the heme in the hemoglobin bond to the cyanide, it changes its color to a bright, cherry bright color, and you don't get the oxygen saturation that you want. On the other hand, we call patient to be cyanosed patient or cyanosis one of the two situation. And please keep in mind, anemia does not have anything to do with cyanosis. If you have low hemoglobin, you're not blue. And if you're hypoxic also, you're not blue. You're only blue if you have either 5 grams of your hemoglobin attached to CO2, or 1.5 of your hemoglobin, 1.5 gram of your hemoglobin attached to the wrong iron, which we call methemoglobin. And so this is very important information here, because if you see a COPD with a hemoglobin of 17 who's blue, you know the total oxygen content, blood oxygen in his blood is okay. You know, he has 12 out of 17. But if you have a sickle cell patient with a hemoglobin of 7 who's blue, you've got a clear, you know, big emergency, and you should ring all the bells here, because he cannot live on 2 oxygenated grams. Where is the mouse? Here we go. You also touch the patient, and if you see a funny rigidity, you see a clonus, and sometimes not only in the muscles, sometimes you see the clonus in the eyes. And that's a buzzword for you here. What is this? And that's a buzzword for you here for neuroleptic and serotonin receptor, both in the exam and clinically. Neuroleptic and serotonin are usually a combination of medication with a history of at least 2 weeks of use. So they're not going to present to you with a suicidal note. These are not the patients who's going to come, you don't know anything about their medication. But a lot of time the presentation is puzzling. Just and simply Google, guys. You know, Dr. Google could replace a lot of us here, but not in the emergency. Is that a serotoninogenic drug? Yes or no? And Dr. Google will tell you that. Guys, I wanna mention that seizure or aggressive patient in tox, you should not add again another drug to the mix. I would shy away from something like haloperidol, for example, or phenytoin, because most of the drugs, guys, are not clean drugs. These are the drugs that have a lot of receptor they're working on, and the safest way to go is benzo. So even if you don't know what you're dealing with, you know what to do for seizing patients, you know what to do with feverish patients, you know what to do with hypertensive patients. And so go by symptoms rather than syndrome, especially if you're overwhelmed and you don't know what to do, you don't know how to read your patient. Look at the patient's skin. If you see marks, then you know there is mix, and most probably they're opioid. There is sometimes funny and sometimes very sad stories about the blisters and the skins. There's two things that is famously causing a blister, and it's so funny. I don't know how, and I don't know, you know, what's the pathophysiology behind it. But if you take the fluid here and inside this blister, it's going to be positive for barbiturate, and so the CO poison patient and the barbiturate poison patient, they will present with blister, and if they are barbiturate, somehow they take the barbiturate PO and somehow it show up in the fluid in the blister. It's interesting, but I'm not sure if it's you know, you could use it once upon a time, but I know the forensic people, they do. I hope that we don't use it in the emergency. And after that, I am hoping that the tox syndrome will be easy for you. You know, just going fast on the tox syndromes. Remember, Matt, as a hatter. The hatter is the job for people who are doing the hats for people, and they were decorating the hat with a lot of silver and mercury, and you know, they would touch their tongue and they would decorate the hats, and they would get mercury poisoning, and they would get mad at the end of the day. And so that's what the saying is come from. Blind as a bat, guys, not because they have a wide pupils. Blind as a bat because the parasympathetic and the third nerve, oculomotor nerve, when it's paralyzed, you don't know, you don't accommodate then yourself. If you're looking at far and then you want to look, you know, at something closer, you can't do it, and so you're blind. Those three here are very, you know, coming from the same thing. Dry as a bone. We said that when we said the anticholinergic, they don't sweat, and so they're dry. Hot because they don't sweat, and so they don't lose their heat, and so they're hot. Red because they don't sweat and they don't lose their heat, and so the blood vessels under their skin try to vasodilate, and so to dissipate some heat, and so they're red. And so with that in mind, I hope that that tox syndrome, it makes sense to you. You know why now. If a teenager came to you and they drank a funny tea or a TCA or antihistamine, which is, by the way, one of the most common presentation, the ED, you know why they're tachycardic, you know why they're hypertensive, you know why they're dry, and so on and so forth. On the same token, why the sympathetic are doing what they're doing. Keep in mind, guys, the agitation and the madness and the whole thing, because we have norepinephrine receptors in the brain. It's a neurotransmitter. We have acetylcholine receptors in the brain, and so all of those are not just systematic; they're also central. The cholinergic here could be tricky. You want to say it's opposite, you know, just opposite to the anticholinergic, because they're wet all over. They're saliving, lacrimation, and GI, and the whole thing. And the killer bee is one of them. You've got a killer bee because you're bradycardic, the acetylcholine guys, the bronchospasm and the bronchuria, because you've got a lot of juices that, you know, squirting, you know, everywhere. But I want to say all of those is because of the muscarinic receptor. The caveat here, the acetylcholine, if you remember, with the preganglionic is also a nicotinic receptor, and there is another receptor here that could clue you into this syndrome exactly, and only this syndrome, which is the weakness and the fasciculation, because there is a nicotinic receptor in the motor end plate that it's not sympathetic, not parasympathetic, it's in the motor end plate, and so you get weak, and you get some fasciculation with the cholinergic. And that's what you're trying to avoid, by the way, when you're treating. You're treating until they are dry from the bronchuria, but you do not want them to be paralyzed. That's, you have to know also what is your goal when you're treating them. The sedative here, when everything is down, but the difference between the benzos and the opioid here is, again, the meiosis. The sedative benzos, they don't constrict the pupils. I've got 4 slides that it's outside the tox syndromes in a very very short way. I want to tell you about the caustic injury, guys. I want you to really remember why, when we have a brain infarct, we've got a liquefaction necrosis in the brain, and then it's empty out, and you see the CT, with all the space. But when you've got infarction in the heart, you've got a hypokinetic muscle. Those muscles are contracting and they're not functioning anymore. And that's because this is more of a lipid in the brain, and this is more of a protein. And, bear with me with odd presentation, but I'm trying to, to hit home here. When you heat the butter, it goes wide. It's just dissipate and it liquefy. But when you heat the protein, it gets hardened and it gets smaller. And imagine and apply the same thing. If you pour on a skin or ingestion a caustic, they would do exactly the same. You would have, because of the protein and the contraction, you would have a chronic constrictor in the esophageal chronically after the caustic ingestion. And so here, try not to put a base on the acid or acid in the base. No, we are trying not to, no harm, right? First, no harm. And we're trying to minimize our losses here. And so assess the damage and irrigate and go on. One caveat in the aspirin here, the aspirin guys, they present with mixed metabolic picture. It's so funny, VBG. Sometimes the pH is normal, but they have very funny VBG, metabolic acidosis, respiratory alkalosis. They have fever, and you look at the pH, you think it's normal, and you say, oh, they're sepsis. Guys, they're not sepsis, and think again. Another caveat about the iron. The iron, the presentation is a trick here. If they present early, you could see it in the x-ray, and that's the only importance of this, that you could actually give them go lightly as gastric cleaning or gastric lavage, not lavage. Help me here. The other presentation for the kids, the babies, when they present, we get a lot of calls. The baby is chewing on a grandma's or on mommy's prenatal vitamins, and they have iron, but they're being in the emergency for 6 hours. They're feeding, they're playing, they're not complaining of anything. Please be in mind that nobody could take iron of a significant dose and have a normal stomach. The iron is so irritant for the stomach. So babies who are been there for 6 hours and they're eating fine, they're not overdose on iron. You can discharge them safely. And obviously the treatment of the iron deferoxamine. Now, one more word about opioid. I'm hoping that we all had this oath once upon a time, and we said we don't judge them. We said we القريب والبعيد والصالح والخاطئ والصديق والعدو. We don't judge those patients, okay? And so in the ED, I'm not gonna hold an opioid for a sickler because I think he is addict. If you think he's an addict, refer him to the addiction medicine, okay? If you think he's an addict, you can give him IV in your ED with a good monitor. You have the naloxone, but do not discharge them on Tylenol 3 or Tramadol or any POs. But do not, give them a life lesson by, watching them in pain. Not just the sickler, anyone who says they're in pain. If you believe them, give them. If you do not believe them, give them, and then refer them to the addiction medicine if you have one. Sometime, very rarely, you're going to need a surgeon for some toxicology cases. And remember that X-ray in the iron slide, there was a chunk of iron in the stomach, and sometimes the surgeon would take it away. And the other case is the body packer. These are people who are usually clean. They are not using the medication. They pack their body with a huge commercial amount with drugs that are illegal. And sometimes they are caught in the court. In the airport or in any port. And so those patients, they should go to surgery, because if one of those bags leaked, it's a lethal amount. And so you don't play with those. It's a surgery tox case. With that, I conclude, and I hope that I add something to your wisdom. I am ready for questions.
Thank you, Dr. Bayan. Very impressive lecture. Thank you very much. And really, we have a question from Dr. Aisha Al-Hajri. Just she would like you to emphasize again on the cyanosis, because it's quite difficult sometimes in the physical examination to tell, especially if in a patient with a dark skin or something. So can you just highlight again quickly what's the cyanosis in physical examination?
When you see the blood, when you see the skin is blue, and also when you take the blood in actually syringe and you see it dark, you don't see it red as usual. I'm guessing you're asking because you did not see one, but it doesn't fool you. When they come blue, they're really blue. There's skin color from outside, and the skin and the blood that you take to the lab. And usually the saturation, they read the saturation always at 85, because that color does not go well with the oxygen saturation. And so it messes up with their oxygen reading or auto-sat. And so I'm hoping I answered your question. Regarding when patients can get blue, I'm going to repeat. If you had 5 grams of your total hemoglobin that it's attached to CO2, ثاني أكسيد الكربون وليس CO, or if you have 1.5 of your hemoglobin having the wrong kind of iron, which we call this methemoglobinemia.
Great, thank you. Dr. Bayan, regarding patient presented with bradycardia, and you have a high suspicion of intoxication, what's your favorite regime to begin with in resuscitation area? Is it like atropine right away, or you will start with other agents?
With the bradycardia, I would go with ACLS. I would go with the normal protocol. If they're hypotensive, then yes, you would go with the blood. If I'm suspecting DIG, then they're going to have a funny ECG. If I'm questioning the beta and the calcium, then the glucose should tell me. And I would jump to insulin in those cases before the atropine.
Thank you very much. Very impressive lecture, Dr. Bayan Abdulbaqi, Senior Emergency Medicine Consultant and Toxicologist in King Saud University. We thank you very much. And now we move to our third speaker, our distinguished speaker, Dr. Hani Ibrahim, Senior Emergency Medicine Consultant from King Saud University and very interested in resuscitations and ECG. I will say if in USA, if they have Amal Mattu, in Saudi Arabia, we have Hani Ibrahim. Thank you very much, Dr. Hani. The mic is yours.
Thank you, Mohammed. شكرا جزيلا. بالعكس يعني شكرا للإطراء. I don't know, الشاشة واضحة ولا؟
Yes, it's quite clear. Please go ahead.
طيب السلام عليكم، مساء الخير جميعا. شكرا محمد، شكرا للجميع المشاركين في الويبينار. I'll start with my talk about the STEMI, to activate or not to activate. Hopefully it's going to be very short and a quick lecture about some of the cases, some of the important situations where you should activate the Cath lab. Amal Mattu again, Mohammed. This is Amal Mattu. He was talking a couple of days ago about the non-STEMI. We have a clear recommendation from the American Heart Association almost 6 years ago about activating the Cath lab, taking patients with non-STEMI to the Cath lab. Certain patients with refractory angina, they need to go to the Cath lab. New heart failure patient or worsening, especially if they do have a new mitral regurg or worsening their mitral regurg, they should go to the Cath lab as soon as possible. Their recommendation within a couple of hours. And any patient hemodynamically unstable with chest pain equivalent, with some ECG changes doesn't fit with the STEMI, they should go to the Cath lab. But definitely those patients with refractory malignant arrhythmia, they should go to the Cath lab. American Heart Association, their recommendation, was clear. All the time we are following their criteria about when to activate the Cath lab for the STEMI patient. We know that if your patient a male, he's less than 40-year-old with ST segment elevation, especially if it's in the anterior lead, you need 2.5 millimeter to activate the Cath lab. 1 millimeter will be enough somewhere else. And if he's more than 40, you go with 2 millimeter. And women, we go with less than that, with 1.5. But today, again, we are here not to talk about the clear STEMI. We are talking about certain situations where you should activate the Cath lab, and when we think that these patients, they need emergent PCI. So I'll start with, just for the marketing purpose, I'll talk about the top five situations where you should call the cardiologist and convince him to take your patient to the Cath lab. Why we are calling the cardiologist? Because again, these 5 situations does not fit in the American Heart Association criteria. They don't have clear STEMI. I'll start with the first situation, which is the new right bundle branch block with the left anterior fascicular block. This is bifascicular block. So if you have a patient with a new right bundle branch with the left anterior fascicular block, this is bifascicular block. And probably your patient, if he presented with chest pain equivalent, they need to go to the Cath lab, because one of the studies they showed that the mortality rate for those patients with the was higher than the other right bundle branch with even the with other changes or other blocks. So the mortality in the new right bundle, again I would emphasize it should be new right bundle branch block with left anterior fascicular block. How would you know? So we know the criteria of the right bundle branch, but just look at carefully. Whenever you see a right bundle branch block, go and check if there is what is the mouse? Yeah, go and check if there is any left axis deviation. If there is left axis deviation, if you look at the lead number 1 and the inferior leads, they're opposite, so it's left axis. Especially the AVF or lead 3, they are going away from each other. This is a left axis deviation. So right bundle branch with left axis, then you go and check the other criteria of the left anterior fascicular block. They do have small, tiny Q wave in the lead 1 and tall tall S wave or deep S wave in the inferior lead. So this is left anterior fascicular block. So right bundle branch, new right bundle branch with the left anterior fascicular block. Probably this is an ischemia, and your patient probably they need to the Cath lab. As I said a while ago, you look at the axis deviation. This left axis deviation with Q1, and we call it Q1 S3, opposite to the S1 Q3. Again, if you look at this patient, he has right bundle branch. The first impression looks like a right bundle branch, and most of the time when we see a right bundle branch, we say, oh, this is probably this is physiological. It's less likely to be pathological, and we take a deep breath. Okay, just do cardiac workup. If you have a right bundle branch, and again, go and check if your patient has a left axis deviation, like in this situation, see the lead 1 and lead ABF or lead 3 that are away from each other. So this is left axis deviation with Q1 and S3 or in the so do you see the Q wave? Some of you, I'm sure they would say, oh, this is a normal. Remember, lead 1, we don't see any Q wave. We don't see Q wave. We don't see any S wave. Basically, we don't see any negative deflection in the QRS. So this small, tiny Q wave represents, a Q wave. So we have Q1 and S3. So this with the left axis deviation. This is left anterior fascicular block. So your patient, he has a left anterior fascicular block with right axis deviation. This is bifascicular block. Your patient coming with chest pain equivalent, they need to go to the Cath lab. This patient, again, he has a right bundle branch with left axis deviation with a left anterior fascicular block. But if you look carefully, this patient also lead like in the AVL. Look at the AVL. He has some ST segment elevation, lead AVL. And again, if you look carefully, even maybe in V1 it's not clear, but V2, we do see some ST elevation. So this patient, he has right bundle branch with some ST elevation here and there, plus the left axis deviation, which is the left anterior fascicular block. This patient needs to the Cath lab as soon as possible. Another patient, look at this patient. This is a right bundle branch with left anterior fascicular block. Probably this is an ischemic. Here I'm talking about a new, remember, I'm talking about new right bundle branch block with left anterior fascicular block. This is bifascicular block. Probably it's an ischemic changes, and your patient need to go to the Cath lab. Good luck with the cardiologist convincing him this is a bifascicular block. Probably has some ischemia is going on in this patient, and he needs to go to the Cath lab. Second situation where you should pay more attention to the ECGs when there is very subtle inferior MI, and we know that in the inferior MI we do see some reciprocal changes in the AVL and lead 1. And if you look carefully in these like 3 patients, patients A, B, C, look at their maybe there is no clear ST elevation in the inferior leads, but if you look carefully at AVL, there is like very subtle ST depression. Malmatu, he call it. There is sagging of the ST segment, which is probably this is the very early change prior to the ST elevation. Even prior to the ST elevation, the inferior leads, you get some very subtle changes in the AVL, especially an AVL. So reciprocal changes will be an AVL, and there will be like a very subtle ST segment depression, as we see here in these the 3 examples. Before even there is an ST segment elevation. Now, we are not talking about this is clear inferior STEMI. So there is the ST segment elevation 2, 3, and AVF with very clear, obvious reciprocal changes in AVL and lead 1. This is different patient. We are here today to talk about this very subtle changes where you don't see a clear ST elevation in the inferior leads 2, 3, and AVF, but look at the AVL. It's there is a very subtle ST segment depression in AVL even before the lead 1, and sometimes this changes, this change in the AVL prior to the ST segment elevation in the inferior. So what you can do, you can just repeat the ECG to see there is a dynamic changes. There will be like an ST segment elevation later on in the inferior leads. What's the definition of this subtle change, this subtle ST segment depression? They're talking about 0.25 milli, which is very, very, very subtle. You cannot see it by your naked eye. Maybe you need a microscope, and you need to be obsessed, with the ECGs so to see this changes. And remember, this is a very important point. Some of the situation can mimic the inferior STEMI because LVA, LV aneurysm, LVH, and WPW, sometimes left bundle branch block, they will have some repolarization, especially in the AVL. And sometimes you will see a normal ST segment depression in AVL, which is nothing to do with the inferior MI. I'll just show you some examples. This is LVH patient. This is normal LVH patient with, he is asymptomatic, but look carefully at AVL. You see some ST segment depression at AVL. This patient, he has normal, changes with the LVH. There is sagging or ST depression, and the AVL, nothing to do with the inferior. If you are in doubt, you could repeat the ECG, do serial ECGs looking for any dynamic changes. But again, this could be a part of the LVH. I'm not saying that LVH patient, they do not get inferior MI. They do get inferior MI as other patients. But if your patient is asymptomatic and if your patient doesn't present with a chest pain or chest pain equivalent, don't be obsessed with this ST segment depression, because this is a normal, changes with the LVH. If in doubt, you can do serial ECGs. Look at the LV aneurysm. LV aneurysm patient, those patients with the previous eye and the anterior, you see like very deep QS wave. Look at their AVL. There is very, very subtle flip T wave, very small flip T wave, or very subtle ST depression in the AVL. Without seeing any ST elevation in the inferior leads, you could suspect this is very early inferior MI. No, this is a normal change with the LV aneurysm, nothing to do with the inferior MI. WPW, which is one of the situation again. Look at the AVL again. AVL here, they do have a normal. So WPW, they do have a normal sagging ST segment at the AVL, and there is no clear ST segment elevation. If you suspect this is a very hyperacute T wave, the inferior leads, go and repeat the ECG, do serial ECG, just to confirm there is no dynamic changes. But WPW could have a normal sagging ST depression, very subtle ST depression at the AVL. This is one of my patients. I saw him like maybe, this is 4 years ago. I saw him with one of the residents. He's a consultant by the way now, just graduated. He told me that I was doing, recess, shift at that time, very busy, and we have to sign, we have to check all the ECG, each and every ECG, you have to look at it. So when I saw this ECG was given by the nurse, immediately I told her, what's his complaint? She said, chest pain. And I asked my resident, do you see any ST segment depression at the AVL? He said, no, there is no, it looks normal. I told him, no, if you look carefully, you could appreciate very subtle ST depression at the AVL. And I was arguing with him, no, look carefully. You look at the J point, it's below the isoelectric line. Go and look carefully over there. You might see, this is very subtle ST segment depression. And I told him, let's go and check the patient. We went to the triage. There was like a 40-year-old male, otherwise healthy. He was sitting in the chair. He said that I had chest pain for the last 6 to 8 hours. So then I asked the nurse to repeat the ECG, and that was his repeated ECG in 10 minutes. At the time we saw him, I asked to repeat. There was like very clear, obvious ST segment elevation in the field leads. And if you look carefully, look at the AVL. Now we have more prominent ST segment depression. And look at lead 1. Still, lead 1 doesn't have any ST depression. And just I'll go back to the first ECG just to show you that lead 1 is still, it was a normal. And lead AVL maybe has very subtle, very suspicious, ST segment depression, which if you repeat the ECG, especially if your patient has chest pain equivalent, probably something will have inferior, MI. So the subtle ST segment depression in the inferior leads, especially AVL, could represent very early inferior MI. And he went to the Cath lab, he had 100% RCA occlusion. Another patient, I was busy with the research, and one of the senior resident, he went to check one patient in the respiratory area who was having cough, short of breath, and he told me that his ECG was fine, and I just asked to do some blood work, chest X-rays and blood work for him. And 30 minutes or an hour later, you know, they called me, they told me that we have a STEMI patient in the respiratory zone, in the respiratory area. I went to check the patient, he was the same patient, you know, and when you look at the ECG, he has very obvious ST segment elevation in the inferior with the reciprocal and the high lateral, especially in the AV up. But, you know, when I look carefully at the first ECG, which was missed by me, I did not, to be honest, I didn't pay attention, you know. I was, you know, dependent on the resident, you know, and when he told me it was normal, I just, you know, scanned it quickly. I didn't pay attention to the AVL. Look at the AVL, there's very subtle ST segment depression, and maybe lead one was normal at that time. And if you look carefully, the inferior lead doesn't have very obvious ST segment elevation, but the repeated ECG, it was so obvious. Now we have very clear ST segment elevation in the inferior with reciprocal in the inferior. This is from the Stephen Smith website. One time he put an ECG and he asked, what do you think? Is it LVH or there is any inferior MI? And we know that LVH patients, they do have ST segment depression and the AVL. So I told myself, this is very obvious, you know, ST depression. With this normally, you know, I wouldn't say there is clear ST segment elevation in the inferior. Probably this is part of the morphology of the LVH. So this is a normal, you know, pattern with the LVH. And then I went to the second ECG for the same patient, for the same LVH patient. I checked his baseline ECG. That was his baseline. In his baseline ECG, even if it was an LVH, he doesn't have any ST segment depression in the AVL. And the T wave in the inferior leads, it was not there. So this patient, he has an LVH, but with the chest pain, he gets an ischemia. And not always that LVH or WBW or LV aneurysm, they will have ST segment depression in AVL. So please, the message here, you should check the previous ECGs before telling this is a normal morphology with the LVH. And you can repeat an ECG if there is no changes. Do a serial ECGs before concluding this is normal, you know, pattern with the LVH. And don't depend always on that. The LVH, they do have a normal ST segment depression. Sometimes LVH, they don't have it. Sometimes they do have like a normal, you know, ST segment. There is no depression, just it's isoelectric. But in certain situations, yes, they do have ST depression. Third situation, where if you convince the cardiologist to take the patient to the Cath lab, if there is a hyperacute T wave or very subtle ST segment elevation in the anterior, I call it the ladder occlusion, the hidden beast. I don't know, this is the total LAD occlusion. I don't know if you see the beast over there, you know, but you know, this is very scary. Whenever you see any ST segment, a very subtle ST segment elevation in the anterior leads, we think it's a normal, especially because most of the time it's going to be very challenging, you know, for us, because you know there is some many situations which could, you know, mimic, you know, the ischemia, but it's not ischemia, like maybe like hyperkalemia or early repolarization. Sometimes you know, left bundle branch block, they will have a normal ST segment elevation in the anterior leads. So it's very, very challenging and very difficult. This is one of the elderly patient. He presented to the emergency with chest pain. And if you look carefully at the anterior leads, there is no very obvious ST segment elevation. And if you apply the criteria of American Heart Association again, which they said that if your patient, you know, more than 40, you need 2 millimeter ST segment elevation and 2 consecutive leads or contiguous leads. And look at V2, V3, they don't have that much ST segment elevation. Also in V1, it's very subtle, just like 1 millimeter ST segment elevation. And you are not going to activate the Cath lab for this patient. But if you go and check his old, you know, ECG, this is baseline. So in this situation, your patient, he has a like very flat, you know, T wave, or the T wave was not, even big enough. But now with his ischemia, you start to have a very obvious, well-formed ST segment and very hyperacute T wave. And if you carefully look at the base of the T wave here has a very wide base, which if you go and check his baseline, this is the T wave. It has a very small or narrow base of the T wave. With ischemia, he starts to have hyperacute T wave, which is, by the way, the definition of the hyperacute T wave is not the tip of the T wave. Also, we look at the base of the T wave. So the hyperacute, what we mean by the hyperacute is the tip of the T wave and the base, also the base of the T wave. And this patient, they repeated the ECG after a while, and you see the ST segment elevations was more obvious here. So this patient went to the Cath lab and he had like LAD occlusion. So just to show you the difference between the hyperkalemia and the acute MI, what's the difference between them? Usually the hyperkalemia, their T wave, they do have a very narrow tip of the T wave, and the base of the T wave is small in comparison to the the acute MI, where they do have like very broad base of the T wave, and their tip is not narrow as the hyperkalemia. I mean, it's not always. This is another situation where we have a very hyperacute T wave in the anterior leads, and the clue here, this is an ischemia, and this patient needs to the Cath lab because this patient's not all. There's not only there is ST, hyperacute T wave. There is ST depression in the anterior leads 2, 3, 4, which is goes with De Winter syndrome. And if you look careful at AVR, De Winter, because it's a proximal LAD occlusion, they do have some sort of ST segment elevation at the AVR. So this patient again needs to go to the Cath lab. Stephen Smith, he was talking about how can you differentiate between the early realization and the subtle anterior STEMI, and it's really challenging. And for the last 10 years, he had lots of cases in his blog, in his presentation, talking about different criteria. How can you differentiate between the early realization and the subtle anterior STEMI? I will just go quickly about his criteria. You can go to his website and take more details. He was talking about initially in 2010 about 3 variables where you can use to differentiate between the anterior STEMI from the early realization. And those 3 variables was the QT interval and ST segment elevation V3 and the R wave in V4. And you should put it like in an equation, and it will give you the value. If the value is more than 23.4, that it goes with the STEMI rather than the early realization. If it's less than 23.4, probably your patient has early realization. After 4 or 5 years, they added another variable. So they put another variable, which was the QRS in V2. And he said that now it's more sensitive and specific. So the 4th variable, by adding the QRS and V2, it will add more value to that equation, and it will tell you if your patient has early realization from subtle STEMI. And here the value is, if it's more than 18.2, it suggests LAD occlusion. So this patient, he was seen in one of the hospital, with chest pain, young male, otherwise healthy. He's a bronchial asthma patient. He went there with non-specific chest pain for the last couple of days, and he looks very fine, very normal. So that was his first ECG. Given some, Ventolin, atropine, he improved. He said that that chest pain becomes less after the nebulizer, and they asked for troponin, and the troponin came to be normal, negative. And the repeated ECG there was no dynamic changes, and he was discharged, with the instructions. And if you apply the Stephen Smith criteria in this very normal ECG, I did the math myself, and it shows 18.5, which goes with LAD occlusion. If you look carefully at the ECG, it looks very normal. There is nothing tells you this patient has LAD occlusion, but if you apply Stephen Smith equation, the 4th variable, it will tell you it's 18.5, which is probably LAD. What happened with this patient, he was unhappy from that hospital. So he went from that hospital to the nearest other hospital where they repeat the ECG, and they repeat the ECG after 1 hour from that. And then when they repeat the ECG, now he has very obvious ST segment elevation, the anterior lead. And they said, how come they missed that STEMI? To be honest, it was not obvious. There was no any clear ST segment elevation at that time. But if you apply a Stephen Smith criteria, you wouldn't discharge this patient. You would keep him. You do more maybe you do echo for the patient who can repeat, another set of troponin. You may involve the cardiology with the decision. But we need more, like criteria. We need more, evidence, of discharging the very low risk patient. Even, by the way, I applied the heart score in this patient. The heart score was very low, which is very safe to discharge a patient. But again, if you apply the Stephen Smith criteria, I wouldn't say that we should diagnose STEMI with Stephen Smith criteria, but I would say you should not discharge any patient, with a questionable, value or questionable result of the Stephen Smith criteria, especially if your patient's like a low-risk patient and you're not happy of discharging him based on one set of enzymes. Again, another thing was, this is, again, Stephen Smith, he was talking about this, specifically about the QRS distortion in the anterior, very subtle anterior ischemia, if you use the terminal QRS distortion. And I'll tell you what's the meaning of the terminal QRS distortion. Look carefully at this ECG. This looks like, if you see this ECG like 10 years ago, by the way, this ECG, Stephen Smith himself, 10 years ago, he said this is early repolarization, benign early repolarization at that time, he called it benign. So, but after a few years, he was talking about terminal QRS distortion. He noticed that if your patient with the early repolarization, they have distorted QRS. What's the meaning of the distorted QRS? If your patient doesn't have an S wave, especially in V2 and V3. Look at V2, there is an S wave, but look at V3. The S wave starts to be shorter and shorter, and it's gone. There is no negative deflection, so there is distortion of the S wave. Maybe here it's more obvious. Look at the S wave here. There is very clear deep S wave, which is very normal. In case of ischemia, he's telling that this S wave will be gone. Look at this patient down here. So the S wave is gone. But if your patient has J wave, which is the fishhawk sign, you cannot call it distorted QRS. This is normal. So when you call it distorted QRS, if your patient doesn't have S wave and your patient doesn't have fishhawk sign. So if your patient coming with chest pain equivalent, and the ECG looks like early repolarization, I would emphasize you should use this criteria in early repolarization. So if your patient has distorted QRS, there is no S wave in V2 or V3, or there is no fishhawk sign, there is no J wave in V2 or V3, this is distorted QRS, and probably it's an ischemic changes, and your patient, he needs to the Cath lab. Again, look at this normal J, there is a fishhawk sign, this is the J wave, and if you look carefully, this is the isoelectric line, there is a deep deflection here. This is a normal finding. This is a normal. But if your patient, he came in with early repolarization, I would emphasize again, your patient has early repolarization and there is distorted QRS. There is no J wave, no S wave, probably it's an ischemia, and your patient needs to the Cath lab. He needs to go to the Cath lab of the possibility of LAD occlusion. This is one of the patients. He came into the emergency with early repolarization, and the ECG at that time, they did it, it was normal. There is like S wave in V3. So they repeat the ECG after 10 minutes and look at the S wave, it's gone. So this patient, he has distorted QRS in V3. There is no J wave, there is no S wave. In a patient with early repolarization morphology, I would emphasize again, in early repolarization morphology, this is distorted QRS, and your patient needs to go to the Cath lab because of LAD occlusion. So to summarize the LAD occlusion, what are the things can tell me about my patient who has LAD occlusion? Look at the QT interval. If there is a QT prolongation, the base of the T wave start to be wide, your patient have QT prolongation, especially, you know, if it goes more than, you know, what's normal, male and female. And repeat the ECG. Please repeat the ECG, because it will give you a clue if there is like a progress of QT prolongation with repeated ECG, probably there's an ischemia. The other thing about the hyperacute T wave, and I would emphasize again about the hyperacute T wave, it's about the height of the T wave and about the base of the T wave. That the base is wide, or the tip is a hyperacute. It probably is a hyperacute T wave. The third thing, look at the R wave in the anterior leads. If you see a poor R wave progression, if you see there is a poor R wave progression in a patient with chest pain, probably it indicates an ischemia. Fourth thing, look at the QRS. If you see the very short QRS in V2, it might give you a clue about, you know, the variable which we talked about a while ago about the Stephen Smith. And you should repeat the ECG to see if there is a dynamic changes. Terminal QRS distortion, I just mentioned that a while ago. It's very important, and it will give you a clue regarding the patient if he has an ischemia, especially in early repolarization. ST segment elevation in AVR is very important in case of Wellens or De-Winters. Sometimes it will help you to tell you there is a subtle ST segment elevation in the anterior leads. Look at the AVR, because sometimes, it's not always, but sometimes they do have ST segment elevation AVR, and that's the clue. And again, look for any reciprocal changes in the inferior. Sometimes with the early anterior, there will be like very early, again, reciprocal in the inferior. And whenever you are in doubt, repeat the ECG or do, you know, serial ECGs, and don't forget to compare them with the old one. The fourth situation where it's very challenging, you know, and you need to, you know, sometimes to talk to the cardiology to convince him to take this patient to the Cath lab. It's very challenging and very difficult, even for the cardiologist, LVH patient. We know that LVH patient, their default, you know, they do have ST segment elevation in the anterior leads. And if you apply the American Heart Association criteria, definitely this is more than 2.5 or 3 millimeter. But it doesn't mean this patient will go to the Cath lab, because we know that part of the morphology with the left LVH, they do have ST segment elevation. So when to take this patient to the Cath lab is very difficult a question, and the electrophysiologists and cardiologists over the last couple of years are trying to find, you know, a criteria or way to distinguish such patients from the normal LVH. So we know that LVH with the strain pattern, they do have very scary, I would say this is very scary ST segment elevation in V2 and V3. And V1 also, but look at V5 and 6. There is a reciprocal for these changes, which is, this is the strain pattern. So this patient, usually, this is your non-compliant hypertensive patient who's not taking his medication. He presented to the emergency with chest pain. And when you see this ECG, we are in doubt. Shall I activate the Cath lab or not? Shall I talk to the cardiology, because this ST segment elevation in V1, V2, V3 is so obvious. So would I consider it as a normal, you know, morphology of the LVH, or there is an ST segment elevation? It's very challenging. What I would advise you should repeat the ECG, look for any dynamic changes, and always look at the previous ECG. But there is a big problem with such patients. LVH patients, you know, over time, they do have normal dynamic changes with their ECG. So if you look at their ECG like maybe 1 or 2 years ago, they don't have such ST segment elevation, because, you know, the LVH morphology is changing over time. And when you see this change, you see, oh, there could be an ischemia. And so the changing the morphology or changing the pattern of the LVH over time doesn't indicate an ischemia. So it's very difficult, very challenging. One of the articles was published maybe 6 years ago. They're trying to see if this patient LVH has an ischemia or not. So they apply the what we call the discordant criteria, like the left bundle branch block. So they went with the same thing, and they're applying the percentage. They are applying the ST segment over the S wave. So if that percentage more than 25, like the modified Scrobozzi criteria for the left bundle branch block. But to be honest, there is no strong evidence behind this. There is no any science, strong science behind this, and no one is following this criteria. So what you should do, you go with your clinical sense. So this is one of the patients. He presented to the emergency with chest pain, and he is LVH patient. He's non-compliant. So if you look at his ECG, it looks like, okay, there is some ST segment elevation, B2, B3, could be part of the LVH morphology. But when they do a serial ECG at that time, so they just repeat the ECG after like 5 minutes. Look at the ST segment now. It's becoming more obvious, especially V4. Look at V4. It's becoming more obvious in comparison to one was done like 5 minutes before. So in this situation, what I would advise the LVH patient, they do have very difficult ECGs. Their normal ECG has a ST segment elevation. They do have dynamic changes over time. So you go with the clinical sense. If your patient, he has an LVH, that is ST segment elevation, and he presented with chest pain, before activating the cath lab, do a dynamic, do serial ECG, look for any dynamic changes. Of course, if you know how to do a bedside echo, it's a great tool to differentiate between ischemia and normal LVH. Look for any hypokalemia or dyskinesia. So this patient with this dynamic changes, he went to the cath lab and he had like 99 occlusion of the LAD. Another patient, LVH, presented to the emergency with chest pain. He has high blood pressure, and he has very subtle ST segment elevation. And because he has very active chest pain, we convinced the cardiologist to take this patient to the cath lab. We told him, if you remember the first criteria I mentioned, but if your patient has angina or has active chest pain, they need to go to the cath lab regardless of their ECG findings. So the cardiologist he agreed with us. He took this patient to the cath lab, to save his life, and cath lab was normal. You should not regret this, because this is this is the normal practice, and we should do this. We are not here to, like doing CT scan for stroke patients, then you'll find a normal CT scan. You should not regret any normal findings, but, just imagine if you did not take this patient to the cath lab. I know I'm going fast, but, because I'll come to the conclusion, I have the final, situation. Just one point regarding the LVH. The LVH, sometimes they do have what they call pseudo-Wellens syndrome. So they do have like biphasic T wave. And remember, you should not, call cardiology for pseudo-Wellens. Make sure they do have like a Wellens criteria, because they do have angina pain, and the troponin usually negative once they present to the emergency. Last case, I would conclude with this. Very difficult. I think we were overestimating we were neglecting the AVR. Maybe like before in 2008, maybe the first article was talking about ST elevation in AVR, and that was talking about the forgotten lead. And now I think we are overestimating the AVR. Every time we see a ST segment elevation, we say, oh, this patient needs to go to the cath lab because there is ST segment elevation in the AVR. I'll just give you some examples that ST segment elevation AVR is not always cardiac. Could represent left main coronary artery occlusion. You see very scary ST segment elevation with the reciprocal ST segment depression elsewhere. Sometimes could represent LAD occlusion, especially if the AVR ST segment more than V1. Look at the ST segment in AVR more than V1. This is probably, it goes with the no, it's opposite. If the ST segment, the AVR more than V1, it goes with the left main. If the ST segment elevation V1 more than AVR, it goes with the proximal LAD. And sometimes massive PE, can present with a ST segment elevation AVR. Just imagine this patient with massive PE who has ST segment elevation and AVR. You call cardiologist and you convince him to take this patient to the cath lab, and his coronary artery is going to be normal. Then they will take this patient back to the CCU where they can observe the patient, and he will have like a sudden cardiac arrest because of the massive PE. Hypertensive emergency sometimes can cause some ST segment elevation in the AVR. Simple thing, SVT, which is, we don't look carefully at the AVR. Look at the SVT. Next time you have an SVT patient, look at their AVR. So they do have ST segment elevation in AVR with ST segment depression elsewhere, it doesn't mean ischemia. It doesn't. This is just rate related. Tachyarrhythmia could cause this. So what the most important thing in this situation where there is ST segment in AVR to differentiate those patients who need to go to the Cath lab. Left main occlusion, proximal LAD, sometimes, triple vessel disease, which is very difficult to know from the emergency point of view. But, what I would emphasize, remember, other patients can have ST segment in the AVR, like massive PE, tachyarrhythmia, SVT, and fast AF, hypertensive emergency, GI bleed or anemia, aortic dissection. Last time we had a patient, with a female in her 50s. She presented with severe chest pain, very poor hysteria. She couldn't give a detailed history to the resident. So the resident, he was smart enough to pick up the echo and do it for the patient. And he noticed that the patient has pericardial effusion with widening of the aorta, the aortic root. So that was aortic dissection. Just imagine if this patient with ST segment in the AVR was given heparin, or if you convince the cardiologist to take this patient to the Cath lab, they will die on table in the Cath lab. Other situation like right bundle, left bundle branch, they will have ST segment elevation. So many situations could mimic the ischemia. Before calling the cardiologist, you should exclude the life-threatening like massive VE or the aortic dissection. Some with the correctable causes like anemia or fluid, severe anemia or any GI loss, could cause some ST segment elevation. So I think the message here, before activating the Cath lab, before conversing the cardiologist to take the patient to the Cath lab, make sure this is something cardiac, before taking a massive PE to the Cath lab, then they will die in the CCU. I think I would, with that, I conclude my lecture. Thank you so much.
Jazakallah khair. Thank you very much, Dr. Hani Ibrahim. Let's have a break for a few minutes, at which we will share some questions, and then we have, guys, please bear with us. Wait with us, please. We have one more lecture to go, short lecture to go, and we will close our webinar. Dr. Hani, you have a question from Rami Al-Ghamdi. He's asking about post-CABG changes, ECG changes. How do you take them seriously, especially in the subtle changes in AVL?
Again, it's very difficult. Some of the post-CABG patients, they will have normalized of the changes because maybe he has ischemia or so sometimes they will have very subtle changes, or sometimes they will have persistent change in the ECG. It's very difficult. It's very challenging. What I would do in such patients, I wouldn't depend it on ECGs. I would go with the echo for such patients. It's very difficult, to be honest. Like the LBH, it's one of the situations. It's really, really difficult.
Okay. We have another question, Dr. Hani, from another trainee. He's asking you, how can I be good in ECG?
You need to read more about ECGs. You need to have more than one resource of the ECGs, and the clinical practice is very, very important. There are many free websites. Stephen Smith, he has his own free blog. Amal Matou, he has paid. I'm not, Amal Matou, he has paid, website. You can join it, which is very affordable, and lots of free resources online.
One more question, Dr. Hani, from Aisha Al-Hajri. She's asking you about the bundle branch, right or left bundle branch. Is it important to know that if they are old or new? And if you don't have old ECGs? Dr. Hani Ibrahim, are you there? I think we lost communications with Dr. Hani Ibrahim. Bayan, are you online? Dr. Bayan, are you online?
Yes, I am.
Yes. Thank you, Dr. Bayan, for your impressive lecture. The people, they liked it very much. We have a question for you regarding calling the patient. They said if the patient presents with fever, high pyrexia, what is your favorite option of calling in emergency department?
For infection control, they ban the fan, but icing and the fan is perfect if you can give it to the patient. Also, usually in resuscitation rooms, we give a temperature-controlled normal saline, which means that they were in like around, I'm not saying 37, but they're heated a little bit. For those patients, you would go with the cold normal saline, like room temperature normal saline could help. And I would postpone the intubation. If you tube a highly acidotic patient, because most of the feverish patients, they're also acidotic, especially if you're talking about aspirin. You do not want to tube those guys. The rapid breathing that they have is their compensation. And so the time you tube them and you paralyze them, you allow this aspirin to go inside the cell, inside the CNS, and bad things happen from there. And so always remember, in tox or any other things, the human body is smarter than smartest physician. And so do not take the patient compensation away.
Thank you, Dr. Bayan. One more question about IV lipid therapy in emergency department. What's your advice? You know, is it really used in your institute?
Lipid therapy is really one of the rescue medication. It does not help with a lot of medication except the medication that dissolve in lipid. And so you've got two, think about it like two types of medication. The medication that you can dialyze them, and these are the medication that are water soluble. But the medication that are lipid soluble, they're not usually dialyzable. So what you're trying to do is to give them a lipid in their blood to make sure that the medication, it goes outside your CNS, outside the cells, into the blood. But first of all, it's not that effective. We go to that step only when the patient is really serious. That's one thing, which you're already late in the game. That's one thing. Number two, it's very, very hard to order any lab after you give the lipid, because the lipid will mess with all the lab results. Like you can't say, I want to know the renal function or the liver function. It's not going to work because of the lipid presence in the blood. So if you're a resident, don't worry about the lipid. If the drug is that much ahead of you, call the expert and pray for the patient. But I would say you would save a lot more patients when you know the basics more, not the more sophisticated. I'm telling you this from experience.
Great. Thank you, Dr. Bayan. Back to Dr. Hani. Ibrahim, you have a question about the presence of chest pain unit in the hospital. Chest pain, some hospitals, they do have special institutes, they have a special corner for chest pain unit. How does it affect really the practice in emergency medicine?
I think that's a great idea. You know, even for emergency point of view, I think having chest pain unit, you know, where the resident, they can see, you know, all the chest pain patient, they can evaluate all the chest pain patient, doing the labs for them, you know, evaluating them, doing some echo, bedside echo for them. I think it's a good opportunity for if we have a chest pain unit in the emergency. And I don't know, some of the hospitals, yes, they do have it, but you know, I think some of the hospitals, the chest pain unit run by the cardiologist, not by the emergency position.
Great.
I totally agree.
That's really good. Dr. Aisha is asking you again about the inferior MI and the possibility of AV block. Do you have any factors that, or a clue to which patient will block?
We know because of the supply, you know, the RCA supply the sinus nodes, so the RCA get occluded, the patient probably will have kind of block. So if you see an ischemia or see very subtle ST segment change in the inferior with any kind of block, it will it will give you a clue. This patient probably has RCA occlusion. Definitely, yes.
Yeah, thank you very much. We have many questions from our candidates regarding the CME hours. Guys, please, we will submit the email to you so that we can receive your registration number, and we will have 2 CME hours for all candidates and the certificate of attendance. Dr. Mohammed Arafat, are you online, please?
Yes.
Dr. Mohammed, we have a question regarding dialysis for hyperkalemia. One candidate is asking, you know, when shall you consider, at which level, at which number, if you can please highlight.
So again, dialysis is not directly related to the number rather than to the persistency or refractory hyperkalemia. So whatever is the number of hyperkalemia, which most likely above 6, because the indication of treatment for hyperkalemia is starting from above 6. So if your patient is hyperkalemic with a refractory to your treatment, you start, then go to dialysis, whatever is the number, 6, 7, 8. So there is no clear cut, any refractory hyperkalemia.
Yes, great. Thank you very much. You know, I would like to thank the 3 speakers, Dr. Bayan, Abdulbaqi, Dr. Hani, Ibrahim, and Dr. Mohammed Arafat. We will move now to the last part of our webinar activity, talking about radiology in emergency department. And as you can see, Bismillah. Just to remind everyone about the email for the registrations of the CME hours, just send us your number at cmemastery@gmail.com, and you will have the hours really registered for you. Now, as we know, our Mastery of Emergency Medicine course is highlighted onto the main 6 aspects of training of emergency medicine. Tonight, we had presented for you ECG and electrolytes on data analysis. Dr. Bayan also highlighted the clinical assessment of intoxicated patients in emergency department. The last part of our webinar activity will talk about emergency radiology. And you know, emergency radiology is a huge specialty. It takes really 2 to 3 years to fulfill in radiology department. Now, let me tell you about 10 lessons I learned from emergency department. I have chosen few lessons for you, which was it's really changing some of our practices, you know. So number 10, we will start by choosing X-ray for patients with chest pain. Maybe Dr. Hani, Ibrahim, you will agree with me. If you have a young patient, 25 years old male patient presented to emergency department with chest pain, he does not have any features of pneumonia, and he is really a young healthy guy practicing in the gym every other week, and we find that a huge variation of ordering chest pain. And I would really encourage our colleague not to request chest X-ray for young healthy patient. It's not indicated, because 99.9% the X-ray will be normal. This phenomena was really studied by many scientists. One of them was Rothrock in 2002. He created criteria for ordering chest X-ray of patients with chest pain. And you know what? He came up with a very nice criteria that was not really taken much. Anyhow, in 2018, Newsom and colleagues in Canada came in with a very nice criteria for ordering chest pain patients in emergency department. So if your patient has a feature of pneumonia, or he's elderly, or having history of DVT-PE, or alcohol abuse, or TB, or he is having hemoptysis or signs of heart failure, then X-ray is indicated. If your patient looks healthy, does not have any previous history, and presented with chest pain for the emergency department, please do not order chest X-ray for them. The chance that you will have an abnormal chest X-ray is 6.4%. 6.4%. And you know, if you look at the things that's really important for us is, does the patient has heart failure, pneumothorax, pneumonia, pleural effusion, or a new mass, you know? Let me tell you something about smoking. Heavy smokers after 50 years of age will have X-ray finding by chance of more than 50%. Half of the smokers after their 50s will have some issues. Some of them, they have micronodules, and it's not the point now to talk about micronodules in emergency department, so you have just to refer them to Bolmo. So one lesson, if you have a young healthy patient with chest pain, do not order chest X-ray for them unless they have features. Okay, number 9. If you are looking for air under diaphragm, as the case of pneumobritonium, you know, patient comes to the emergency department, he's quite sick, he's in resuscitation, you are giving analgesia. Please be careful that when you look for air under diaphragm, the patient should be sitting on the bed, upright position, so that the air, and then allow this for 5 minutes, allow the patient to accumulate some air under diaphragm, and then shoot the X-ray. So that's really a good chance for you to pick up air under diaphragm. But you know what? Sometimes the air under diaphragm is quite clear and obvious, huge under the right hemidiaphragm, as we can see in this patient. But on other indications, and you can tell here's a very faint air under diaphragm, which will be missed by most of us, you know. So what's the other method? If the patient cannot sit, then you have to do the decubitus film. So you flip them on their side, right and left, and you wait for 5 minutes. They will accumulate air, then you shoot the X-ray. For example, this patient is having a feeding tube, and we flip the patient downward. You know, his left side is down, his right side is up, and that's the liver over there. And you can see here clearly the pneumobritonium. Pneumobritonium is very important. You know, CT scan is the best. Sometimes the patient's quite sick to send them to a CT scan, so that we need to speed up the diagnosis and get the surgeon quickly to assess the patient. So this is what we usually do. So if you order CT scan for those patients, use the pulmonary lung window, and use the lung windows to scroll down to the abdomen to look for pneumobritonium. So I will use the lung window, and then I'll go down with the lung window to the abdomen to look for pneumobritonium. And you can discuss the cases with the radiologist. Sometimes the pneumobritonium is very small and subtle, like, you know, sealed, perforated viscous. Sometimes it's huge. So you need an expert radiologist to help you to detect pneumobritonium. Okay. Other signs that you can say, you know, you can say right now, football sign, double bubble sign, cubular sign, lesser sac sign, triangle sign. All of these are accumulation of small air in the abdomen. It will be picked up really by the good radiologist, you know, and no need to go into the details. We have more than 20 signs of pneumobritonium. Just leave it for our colleagues in radiology. A very nice, I have seen few cases of this syndrome, air under the right hemidiaphragm, but actually it's not air. Actually, it's really the colon, you know, and it was picked up by Sheladiti, Demetrius Sheladiti. He was an Austrian radiologist, and he studied this phenomena at which the colon really interposes and goes just under the diaphragm, and it's called hepatobiliary diaphragmatic interposition of the colon, HDI, you know, hepatobiliary diaphragmatic interposition of the colon. And this syndrome is quite interesting. If you see it, you know, you just involve the surgeon sometimes if the patient is having severe abdomen, because the colon might perforate in that tight position. Anyhow, it's a rare, quite rare syndrome, but interesting for the sake of knowledge. Number 8, Number 8, you have an elderly female patient or male. They come with a hip pain after fall trauma. You have done your X-ray and the X-ray is negative. So what to do from there? Where to go from there? The X-ray is negative. Look at this patient. This patient is an elderly female patient, came into the emergency department after fall trauma. And you have look at the X-ray there. The hip X-ray is negative. There is no fracture. The Shenton line is beautiful here. The greater trochanter, lesser trochanter, neck of femur, acetabulum, ischium, you know, there is no fracture in both projections, anterior, posterior, and lateral. So what to do? So the next step is to do CT scan. So you go ahead and you order CT scan, and CT scan is negative as well. So what do you do now? You admit the patient for painkiller, you discharge her with a walker or a stretcher or the family. No, please do not do that one. You know what? You need an MRI. You need an MRI. This is the lesson I learned. MRI is excellent for proximal femur fracture. Excellent. You know, that fracture was missed by CT scan. And as you can see here in MRI, it's beautifully really visualizing the intertrochanteric fracture the patient went for surgery. She needed DHS, dynamic hip screw. MRI is really good. This MRI and CT scan debate for occult hip fracture is very interesting. Some people against and some people with. But really the bottom line is that MRI is excellent for proximal femur fracture. If you have a negative CT scan, please do not hesitate to order MRI and convince your radiologist to do it. Sometimes we refer the patient to another center if we don't have MRI in our hospital to do this procedures. Harun Rahman studied this phenomena. He favors the CT scan. Another article by Hepro and published in Injury Journal in 2015. And you know what? Hepro and his colleagues, they found MRI is superior to CT scan in detecting proximal femur fracture. In this case, I can show you right now the intertrochanteric fracture and transcervical fracture of the femur was missed by the CT scan, was beautifully picked up by the MRI in T1 weighted and stir images. So MRI is really good in detecting proximal femur. Maybe you have a disagreement by ortho or radiologist. This is really science. You have to do sometimes both images for the patient. Okay, number 7. You have a patient with headache. You send the patient to CT scan, and you receive a telephone call from the radiologist telling you, I need to give contrast. So if the radiologist was looking for you, calling you to give contrast, please listen to the advice. Give IV contrast. Giving IV contrast in CT head is really an excellent idea. Sometimes it saves a lot of time for diagnosis. Actually, you have to meet the family of the patient. You do discussion. Sometimes, according to the policy in your hospital, you have to take consent for giving contrast, you know, and if the family refuse or they're giving you problem, just bring the patient back to their bed in the emergency department, give them time to think and revisit the issue, and you can consult. You know, if you have a brain mass, this patient by default needs admission. And as you can see, we have to give contrast because we want to know the diagnosis. Is it really an abscess or a tumor or metastasis? You know, we have so many diagnoses in the brain parenchyma that really sometimes highlighted beautifully by the contrast. You know, for example, if you look at the brain tumor, 1/3 of the brain tumor is glial brain parenchymal tumor arising from the brain parenchyma itself. You know, and astrocytoma is really the most common brain tumor, and it's really subdivided into high grade, intermediate, and low grade. And the high grade astrocytoma is called GBM, glioblastoma multiforme. And you know what? In CT scan, they have a very nice ring enhancing lesion. And it's really very beautiful to give contrast for those patients, very delineating, so you can tell the mass. Abscesses, metastasis also, they have a very nice ring enhanced lesion. We give contrast to reach the diagnosis. The contrast is very safe, and we have now different low ISO density contrast, does not give any problems. For example, look at this patient, 52 years old female, presents to the emergency department with headache. When we did CT scan, we found a small calcification. You can tell here, small calcification on the CT scan does not explain the seizure. You know, she had headache and neck pain and seizure, and this was very suspicious. The radiologist was very smart. He wanted to give contrast. He went ahead, he gave contrast, and he discovered a very nice, very significant destruction, an invasion by a brain mass lesions. An MRI, patient was admitted. MRI shows huge infiltrative brain tumor, huge infiltrative brain tumor. It was really astrocytoma. So giving contrast is very useful. Please listen to the radiologist when they, and this is a very important point I want to tell. If you have an interesting case, please take 5 minutes to call the radiologist, or if it's really close by, you can visit them. If they are in the same institute, you can discuss the cases with them. I have a very good relations with the radiologist, and sometimes we agree or disagree on cases, but that's really the beauty of emergency medicine. Number six, look at this patient, came in with chest pain and cough. Elderly patient came into the emergency department. He had a chest X-ray, very busy emergency department, was sent home with antibiotics, etc. The radiologist called back again to the emergency department. He said, guys, please bring back the patient. We need to see him again. You know why? Because he is having an upper apical mass. Was missed by the radiologist, you know, so patients came in back, so he went for CT scan admission, etc. Apical region, and so the lung apex and the lung base are two difficult sites, you know, for interpretation. They are difficult because they are small and hiding behind the bones. So you have to be very smart. You have to look, you know, for abnormalities, etc. Especially if the patient is having shoulder pain. Another case, you know, look at the lung apex. You know, if you look quickly in a busy emergency department, you can miss those cases, and even larger sites, you know, can be missed as well in a hectic emergency environment, you know. So this patient's having another haziness of the lung apex. This really disease was studied by this Austrian American intelligence professor, you know, Professor Henry Pancoast. He was actually the first professor in radiology in the United States in 1911. You know, this professor, he was actually doing surgery. Then he quit the surgery. I went to radiology, and in radiology, he studied the aggressive apical tumor, and it was given for his name as well. The tumor is very aggressive, invading the apex of the lung and giving a lot of pain. You know why? Because of the brachial. The tumor invades the brachial plexus and giving a lot of pain. One of my patients needed ketamine infusion, you know, just to relieve his pain, you know. So these tumors are aggressive. We admit patients usually on a very high dose narcotics just to relieve this pain. They need chemotherapy, surgery, and radiotherapy. You know, the mortality was very high a few years ago, but nowadays the survival improved to more than 30%, 5-year survival, more than 30% in a very good oncology center. Number 5, this is a very interesting topic. We have question about foreign bodies in the foot and the hand every day in the emergency department. What to do? Shall we do a regular X-ray, ultrasound, CT, or MRI? You know, how can I imagine someone was really cleaning or working at his home and he has a piece of wood in his finger? What X-ray shall I do? This question was studied actually by nice interventional radiologist, Dr. Christopher Ingraham from US, from Salt Lake City, from US. And you know what? He studied this very, very well, and he gave us the answer. If you read this paper, you will not need any other resources to read. Look at this boy, for example. 11 years old boy was really playing in the bush. He fell down from the tree 3 meters height, and he has a foreign body inserted and impaling in his thigh. X-ray was negative. The X-ray was negative, did not pick up any foreign body. When we did CT scan was done for him, and it shows a very large branch inside the thigh, penetrating through the obturator foramen. Okay, so Dr. Ingraham said, let's study this one. So what did he do? He brought an animal model, and he put all the foreign bodies we encountered in the emergency department inside. So he inserted more than 20 foreign bodies inside the phantom animal model, and he scanned the cadaver. He scanned the leg phantom. And you know what? Look at this X-ray. For example, he inserted 16 foreign bodies, including wood, glass, fishbone, plastic, and nothing showed up in the regular X-ray except few, the glass and the gravel and the fishbone. Maybe 3 or 4 foreign bodies regular X-ray. X-ray is very lousy. It's not good to show foreign bodies. You need more images. You know, ultrasound handy. Those people are interested in point of care ultrasound emergency department. Please use them, especially if the foreign body is really superficial. Look at the foreign body there, gravel, plastic, and glass. If the foreign body is superficial, maybe ultrasound is really good. Sometimes the foreign body is very deep and very difficult to see with ultrasound, so you proceed for CT. CT is really good, and here you can see all foreign bodies are obvious, either the foreign body itself or the tract or the effect, glass, aluminum in CT scan was really beautifully shown. MRI, not good quality for foreign bodies, you know, whether it is T1 or T2 or STER image, not good. You know, MRI is not good modality. Actually MRI, when we compare, when it was compared to ultrasound, CT, or regular conventional radiograph, MRI was not good. Please do not consider MRI for foreign body. CT scan and regular X-ray is really, CT scan is really the best. And as you can see, this patient, for example, was cleaning his, you know, he was cooking and using like, preparing fish, and there is a spike of fish bone inserted in his finger, very subtle in the, another one stepped on metallic screw, broken his foot. You know, it was quite, you know, metallic objects are quite obvious on regular X-ray. Glass, this guy had a glass embedded in his foot, difficult to see in X-ray. So CT is really the best. CT and regular X-ray is really the best. Okay. Number four, busy emergency department. You have lots of patients coming, patients going, patients admitted, and lots of nurses around you asking. And you know what? You need to be focused. You need to look for X-rays very carefully. Even you or the radiologist, we can miss diagnosis. Diagnosis error is a human. We are a human being. If you practice, you will miss. If you don't practice, you will not miss. Only those people sitting in the office will not miss anything, will not have any complication, will not have anything. So, you know, if you practice in the field of emergency medicine, you will have a chance of error diagnosis. And that's because we are human. Look at this patient, for example, came in with cough, chest pain. X-ray, normal, completely normal. It was read by the radiologist. This X-ray was read by the radiologist to be a normal X-ray, a normal X-ray. And you know what? Well, you know what? He went to another center, and there's a small micronodule, less than 1 centimeter, small nodule there in the lung. He went ahead and they have a CT scan, and the nodule now is obvious. The nodule is obvious. So sometimes it's really, if you concentrate, maybe there's another one here, maybe there's another one here or another one here. So it's sometimes quite difficult to see small lesions on X-rays, you know. Perceptual errors of small things, really it happens every day. We should never get the negative or feel bad if we miss few things in emergency department. It happens to everyone. That's why we should discuss, do more images, etc. Sometimes you can see, sometimes there is another problem of error in the emergency department. For example, this patient came in with chest pain to the emergency department. And the X-ray is very quite obvious. He has a large mass in his chest or a chest wall, you know. But you know what? This mass was interpreted by the ER physician to be infectious, of course, infectious etiology. He isolated the patient, he gave antibiotic, etc. But indeed, this patient does not need isolation. If you look at the mass, the mass is very smooth. It has a pleural base. It's very homogeneous, and there is minor reaction in the lung parenchyma. That will tell you that this mass is not really an infectious. It's really a slow-growing mass over years and years. And that's maybe very classical of mesothelioma or fibroma or lipoma arising from the pleural space, or maybe another patient needs biopsy for sure. But this mass looks really not infectious. Patient does not have an indication for isolation. So it was an interpretive error, you know. So whether we have perceptual error or interpretive error, it can happen in emergency department. We'll learn. We should never be negative about it, you know. We are here to learn. We learn in emergency medicine every day. Number three, wide mediastinum. Very common problem, you know. Away from the trauma or the aortic dissection or the aortic aneurysm, there is a very interesting entity I learned from the radiology. One time I have a patient with a wide mediastinum. I went to the radiology department. I was discussing with our colleague in radiology, and he really taught me very nice things. I like it, you know. I will just show it to you. Here is another patient, smooth superior mediastinal mass, patients having cough, chest pain, and weakness. And here is another one as well, superior mediastinal mass, patients having cough and chest pain. And you know what? The radiologist told me a very nice things, and I will tell you right now. If you have a smooth superior mediastinal mass, think about the T's, you know, thyroid, T-cell lymphoma, teratoma, or thymoma. So you need to admit the patient, do CT, and then proceed. Please do not forget the 4 T's for superior mediastinal mass. I learned this one while I was caring for one patient with thymoma. Number two, appendicitis, query appendicitis in a pregnant woman. Nightmare. Please give me trauma, radiology, cardiology, but don't give me a pregnant woman with abdominal pain. They are difficult to handle. Anyhow, so you have here 20 years old female. She's pregnant, 32 weeker in the 3rd trimester, presented to the emergency department with right-sided abdominal pain for 2 days, fever, vomiting. She was febrile on arrival, tender on the right side, tender in the subhepatic area, tender everywhere. Very difficult to exam. Anyhow, we went ahead, we gave her some fluid, we gave analgesia, we gave antibiotic, etc. And you know what? Her white cell count, not surprisingly high in the 3rd trimester, and even it can get higher. And we went ahead to order ultrasound. It was difficult. Ultrasound, they could not visualize the appendix. Appendix was not visualized. So the patient needed MRI right now. The family was refusing. We went again and again. We got a surgery consultation. We got an OP consultation for the patient. Pregnant woman, right-sided flank pain, fever, high leukocyte count. We have a questions of query appendicitis. She needed MRI. The family refused. It's a very difficult situation. So we admit the patient there under surgery, and then for 2 or 3 days, on the 3rd day, the family agreed to proceed for an MRI. The 3rd day, you know, patient was, you know, she had already the perforation, you know. So very difficult scenario. Appendicitis in pregnancy can perforate, and it will lead to complications on the mother and on the fetus as well. Please, you have to reach a diagnosis early. You have to operate early. Actually, operating early in pregnant woman is better than waiting for the diagnosis and the perforation to occur. You know, even if you have negative appendicitis after surgery, negative appendectomy, you know, so the complication of negative appendectomy is much better than perforation in 3rd trimester. Okay, so anyhow, but just I want to remind you that the uterus is really enlarging in the pregnant woman, pushing the appendix to the side and then to the subhepatic area. So by the 3rd trimester, the appendix really is in the subhepatic area, but the tip is pointing toward the uterus. That's lesson number one. Lesson number two, the appendix tip. The tip of the appendix can be inflamed, but not the full length of the appendix. Very difficult scenario. MRI is good option. You know, if look at this MRI here, pregnant woman, here is the baby inside, and the appendix is quite inflamed. Good pick up. Another patient went for CT. CT scan was also positive for appendicitis, and here is the baby inside, and the appendix is really inflamed as well. Anyhow, so if the family agrees with you, MRI, ultrasound MRI is really the best to do in pregnant women, and the result is really no doubt. MRI is much better than ultrasound, and this is the study done by Israel and colleagues in 2008, published in the Journal of MRI. MRI was superior to ultrasound, no doubt, in picking up appendicitis. The last but not least, you know, the best and the best really lesson I learned in emergency medicine is from our scientist, Professor Ian Steele. I think Professor Ian Steele came up with many studies in emergency radiology. Many studies saved billions and billions of dollars to the Canadian government. But you know what? His Canadian CT head roll is really outstanding, you know, and it was validated, and in many countries, it was really applied. In many countries, it was printed out, European, Australian, American, Canadian, African countries, Middle East. The Canadian CT head roll is really the star paper in emergency radiology. And please remember this statement: avoid driving if you get SS matched and vomit, and that will simplify the criteria for the Canadian CT head roll. The A and D defines the high risk, while the GSS and AV defines the high risk for their one. So amnesia and dangerous mechanism for the immediate risk, and while the other GSS AV for the high risk patients. So CT heads only required for minor head injury patients if they meet one of these criteria. Please, I want you to print the Canadian CT head roll and post it in your department and follow it. It does not miss any serious injuries, as validated by many international centers. And by this, I really conclude my lecture. And back to our colleagues, Dr. Hani Ibrahim, Dr. Mohammed Arafat, Dr. Bayan Abdulbaqi, thank you very much from deep of my heart. I would really, without you, this webinar could not happen. I really thank you very much. And the microphone is yours, Dr. Mohammed Arafat. دكتور بيان.
هلا thank you very much وكل عام وانتم بخير وإن شاء الله الأيام الجاية نتلاقى على خير إن شاء الله.
Thank you very much. دكتور هاني إبراهيم.
شكرا يا أبو محمد، يعطيك ألف عافية. شكرا جزيلا صراحة على الويبينار. أنا عندي سؤال صراحة لك يا أبو محمد.
تفضل.
Regarding you mentioned doing the MRI for the neck of femur.
Yes.
And it's better than the CT.
Yes.
So would you go immediately for MRI? You skip the CT, or if the CT is negative and still you are suspecting the fracture, you go for the MRI?
Very good question. Thank you very much. Actually, it depends on your institute. The MRI is proven by many papers to be superior on CT, superior to CT scan. But if you do ultrasound, if you do X-ray, and if you do CT scan, and still the patient is not moving, they did not pick up any fracture, the patient is unable to bear weight, then I will admit the patient for MRI. Definitely, I will proceed for MRI. But if you pick up the fracture with X-ray and CT scan, I think that's really enough. You know, CT scan is readily available, and you can do it quickly, and it's really even cheaper than MRI. I totally agree with you. But you know what? The sensitivity, the negative predictive value of CT scan dropped down because of 2 or 3 cases missed by the CT. So MRI is the best, but maybe I think you defer it. I agree with you. You can do it at a later stage if the patient is unable to mobilize.
Thank you.
Thank you very much. Thank you guys. And we conclude our webinar here. شكرا جزيلا وتمسوا على خير وفي أمان الله. مع السلامة.